Welcome to MS Monthly Reports. I'm Dr. Alex Ray Grant, Director of Education at the Mellen Center for Multiple Sclerosis, Cleveland Clinic. I'm Director for this activity. I'm pleased to introduce our speaker for this program, Dr. Jeffrey Cohen. Dr. Cohen is Professor of Medicine in the Cleveland Clinic Lerner College of Medicine. He trained in neurology and neuroimmunology at the University of Pennsylvania and has worked at the Mellen Center for 20 years. He is now the director of the program here as well as director of the Neuroimmunology Fellowship and the director of the Experimental Therapeutics Research Program. He has authored over 180 papers concerning immunological, imaging, and clinical aspects of MS. He is involved in many clinical trials at an international leadership level. He will talk today on where we stand with stem cells for multiple sclerosis. Dr. Cohen.
Well, welcome everyone. I am Jeffrey Cohen. I'm director of the Mellen MS Center at the Cleveland Clinic. And in this presentation, I will be discussing cell-based therapies or stem cells for multiple sclerosis. So the learning objectives for this presentation are listed here. I will give you some background about stem cells so that you're familiar with their biology at a general level. And then I'll provide some descriptions of some of the specific cell-based therapeutic strategies that have been considered for multiple sclerosis. And then finally, we'll talk a little bit about the potential benefits, risks, and methodologic uncertainties that are still present concerning cell-based therapeutic strategies. So let's start with a case history. So although stem cell therapy, I would say, is not yet a standard treatment for multiple sclerosis, it certainly is something that we frequently discuss with patients during office visits. So, and I think this case history illustrates a typical scenario. So a 57-year-old woman who you followed for a while with long-standing secondary progressive MS returns for a routine follow-up visit. She is non-ambulatory with severe leg weakness and also has moderate arm weakness and ataxia. So she has significant disability. Her last relapse was more than 10 years ago, and her MRI last year showed no new or enhancing lesions. When you're discussing aspects of therapy, she asked whether bone marrow transplant or stem cells isolated from fat tissue might be a potential treatment for her. She's been on the internet and has seen descriptions of these approaches, which sound very promising to her. So let's go through a couple of several questions. So first of all, which of the following is not an appropriate way to respond to her question? First, there are a variety of cell-based therapeutic approaches under investigation, each of which has its distinct potential risks, benefits, and goals. Second, that stem cell therapy is widely available in the United States, but she needs to go to one of the clinics that offers it, which she can find on the internet. Third, stem cell therapy shows promise, but is not yet a proven therapy. And then fourth, that there are a sizable number of clinical trials of stem cell therapies that are now underway or are under development. So the correct answer here is 2. You should not tell her that stem cell therapy, although it appears to be widely available, is something that she can pursue. One of the points I'll try to make in this talk is that stem cell therapy still is very much experimental with lots of uncertainties, and I'm of the opinion that it's not yet appropriate to be offering this on a routine basis. So let's go on to question 2. So for which of the cell-based therapeutic approaches listed below are the most clinical trial data currently available? First, immunoablation and reconstitution, mesenchymal stem cells, embryonic stem cells, oligodendrocyte precursor cells, or stem cells isolated from umbilical cord blood. So the correct answer here is 1, immunoablation and reconstitution. So this is so-called bone marrow transplant or rebooting the immune system. So even though the data are still somewhat limited, that's the aspect of cell-based therapy that so far has had the most formal study. Third question. So for that approach, what is the principal remaining question? First of all, for whom does it work? Who are the most appropriate patients for that therapy? 2, how does one prevent the associated osteoporosis? 3, is the benefit durable? In other words, long-lasting? Or 4, based on the risks and benefits of this approach, what is its utility relative to other potent MS therapies that are already available or soon will be approved? So the correct answer here, I think, is 4. As I'll show you, there already are some data that this approach is effective and that provides some guidance as to for which patients it's effective. Osteoporosis is not one of the adverse effects, and the beneficial effects appear to be long-lasting. So really, the main question remaining for this approach is, well, where does it fit into our overall treatment algorithm? All right, so here, let's now turn to my presentation. So to try to answer some of the learning objectives I outlined previously, my talk will be structured this way. First of all, I'll give you a little bit of background about the biology of stem cells. One of the messages being that there are different kinds of stem cells. I'm not sure all patients and clinicians appreciate that fact. I'll then describe so-called immunoablation and hematopoietic reconstitution. We'll then turn to several stem cells that have received some attention as potential ways of repairing the damaged nervous system in multiple sclerosis. And then finally, I'll give some summary comments. So many of my comments today are based on discussions that were held at this consensus conference, which was organized last month under the auspices of the International Advisory Committee on Clinical Trials in Multiple Sclerosis, a committee that I chair and which has been sponsored over the years by the National MS Society and the European Committee for Treatment and Research in Multiple Sclerosis. So we gathered approximately 80 experts in cell-based therapies, stem cell biology, clinical trials, and imaging to review the status of the field and to make some recommendations for moving the field forward so that we can determine the utility of cell-based therapies in multiple sclerosis. So many of the comments I'll be making today are an offshoot of our discussions at this meeting. All right, so this slide provides a definition of stem cells. Several characteristics have been defined, which have been put forth as defining a stem cell. So these are cells, the population of which is self-renewing. In other words, replication of stem cells reproduces the supply. They are pluripotent. In other words, they're capable of differentiating, developing into other more mature cells. And third, they are capable in vivo of reconstituting tissue. So they don't just reproduce the cells in that tissue, but they reconstitute a functioning tissue. So this slide illustrates a scheme of the overall development of stem cells. Initially, stem cells arise from the fertilized embryo, from the blastula, which is one of the earliest stages in embryonic development. And at that stage, the embryo is essentially made up of stem cells, so-called embryonic stem cells. And then as we move our way down this sequence, those stem cells mature from cells that are that divide and are able to, in principle, develop into any cell of the body. They go through a series of sequential events in which they become increasingly more committed to a specific cell type. Some of the signals for this are not yet fully worked out, but it probably involves the environment in which they find themselves and their interactions with other cells in that tissue. And then ultimately, cells proceed from being a completely undifferentiated stem cell through a number of stages, becoming the differentiated cells that make up the various tissues of the body. Now, if you look at on the left side of this figure, it shows that embryonic, tissue-specific stem cells and somewhat more differentiated cells, so-called progenitor cells, are also present, we now realize, in most tissues of the body. And these are the cells that allow tissues to repair themselves when they undergo damage or just due to normal wear and tear. So in what ways might stem cells be of benefit in multiple sclerosis? So this slide shows three aspects of the pathology of multiple sclerosis for which cell-based therapies potentially could be of benefit. So on the left-hand figure, this shows one of the perivenular inflammatory cuffs that are present within the central nervous system in multiple sclerosis. So this aspect of the disease potentially might be amenable to stem cell therapy, because some of the strategies I'm going to tell you about have potent anti-inflammatory properties. In the middle figure, this shows three axons going across the figure. The lower two axons show areas of demyelination. This is one of the characteristic pathologic hallmarks of multiple sclerosis. And then the third axon at the top has been transected and has formed one of these axon retraction balls at the end. So this is the reaction of an axon when it becomes transected. So the second aspect of multiple sclerosis for which cell-based therapies might be helpful would be by serving in a neuroprotective role, by protecting the nervous system from the damage that multiple sclerosis causes. And then on the right-hand side of the slide, this shows the fact that even within chronic lesions of multiple sclerosis, there are in many of those lesions, there are numerous oligodendrocyte precursor cells as depicted with the arrows. And then in the lower figure on the right, this shows that some of those cells actually extend processes and attempt to remyelinate the demyelinated axons. However, as we know, in many lesions of MS and in most patients with MS, these intrinsic repair processes are inadequate, so that over time damage accumulates and disability worsens. So the third aspect of multiple sclerosis for which cell-based therapies might be useful would be either by replacing the naturally occurring stem cells, or by creating a milieu that is more amenable to repair. So these are the three aspects of multiple sclerosis that have been discussed as a potential target for cell-based therapies. Now, what are some of the potential complicating factors that we've encountered as we've tried to develop these approaches to treat MS? So those are listed on this slide. So first of all, as I just showed you, the pathologic process in MS has several features, all of which will need to be addressed as one develops a therapy. So either the cell-based therapy will have to have anti-inflammatory effects, neuroprotective effects, and repair-promoting effects, or the cell-based therapy approach will have to be combined with other treatments. MS is a multifocal disease, so one has to account for that when one administers cells. So you either have to inject them into multiple places, or the cells have to be given in a way that allows them to reach multiple places, or the cells need to have the ability to migrate throughout the tissue. MS is a chronic disease, and so we have to take that into account when we develop a cell-based strategy. There may be certain times in the disease when cell-based therapy is more relevant than others. I made this point earlier that regeneration not only requires cells differentiating, but they have to be functionally integrated. So, for example, oligodendrocyte precursor cells not only have to differentiate into mature oligodendrocytes, but they also have to appropriately interact with demyelinated axons and reform functional myelin. Many therapies in multiple sclerosis that were thought to be anti-inflammatory, in fact, have had a paradoxical effect of leading to immune activation. And there are some reasons to be concerned about this as a possibility with some of the cell-based therapies. So that's something that we'll have to watch for in our clinical trials. And then the last 2 points bring up sort of an intriguing idea that part of the reason why MS may worsen over time may be failure of intrinsic repair mechanisms. So there may be something about the immune system in patients with multiple sclerosis, or something about the CNS in someone affected by MS, or something about the therapies that we use to treat MS that are inhospitable to stem cells, the intrinsic stem cells, or stem cells that we administer. And then finally, a theory has been proposed that because of these factors, or perhaps something intrinsic to the disease itself, that stem cells in MS patients may in some way be deficient. That may be what leads to progression, is the deficiency of the patient's own stem cells and the failure of their intrinsic repair mechanisms. All right, so let's now talk about several specific cell-based therapeutic strategies. So the first one I'm going to discuss is so-called immunoablation and reconstitution, what has also been called rebooting the immune system. So on the left-hand side of the slide, this shows that schema that I showed you before, and this illustrates that that this approach is based on utilizing stem cells that are present in the adult. So the rationale is that one eliminates the autoreactive immune system in a patient with multiple sclerosis, and in other words, replaces it with a new immune system. So one aspect of this approach is immunoablation, and this is accomplished in various ways, either high-dose cytotoxic agents, immune-depleting monoclonal antibodies such as alemtuzumab, or total body irradiation, or some combination of these approaches. So one of the debates still in the field is which of these approaches to immunoablation is the most appropriate. And then the second aspect of this approach is then immune reconstitution. One can allow this to happen spontaneously, or one can transplant hematopoietic stem cells isolated either from the bone marrow or the blood of a patient from MS or from someone else. And a second area of debate in this field is the relative advantages and disadvantages of those two approaches. The difference is not only the time it takes for the immune system to reconstitute, but there may be some qualitative differences in the reconstituted immune system based on whether one allows it to happen spontaneously or one gives it a head start by stem cell transplant. So this slide lists three clinical trials of this approach that were published in 2015. And each one provided important information, and then each one had some important drawbacks. But these three studies largely kind of summarize the state of the field in hematopoietic stem cell transplant and immunoablation for multiple sclerosis. So the first trial, the ASTEMS trial, was important because it was one of the few trials of this approach that had an active comparator arm. In this case, 9 patients were randomized to immunoablation, hematopoietic stem cell transplant, and 12 patients were randomized to receive mitoxantrone. And then patients were followed for 4 years. And benefit was shown on a number of clinical measures of the inflammatory aspect of MS, new lesion formation, gadolinium-enhancing lesions, and acute relapses. So this trial was important because it starts to provide some context for this approach by comparing it to one of the other potent immune therapies. But it had several drawbacks. One was the trial was very slow to accrue patients, so it was conducted over quite a few years. It was, as a result, a relatively small trial. And because it was a trial that was started quite a few years ago, the comparator, mitoxantrone, is probably not so relevant to current clinical practice. It's not an agent that we currently utilize. The second trial, the so-called HALT-MS trial, was a formal NIH-funded study of patients with active relapsing-remitting MS and worsening disability, despite one of the approved therapies. So this was a single-arm study enrolling 24 patients who then received immunoablation and hematopoietic stem cell transplant. The 3-year data have been reported, and follow-up up to 5 years is planned, and those results are just starting to emerge now. In terms of results, very potent benefit was seen with almost 80% of the patients being free of events, including MRI lesion activity, relapses, or disability worsening. The drawbacks of this study were that there were some adverse effects, although there were very few unanticipated adverse effects. It was a relatively small study, and it was an uncontrolled study. There was no comparison group. And then the third study listed on this slide was a large case series of patients treated at Northwestern that included mostly relapsing-remitting patients, but a few patients with secondary progressive MS. One of the unique aspects of this approach was a somewhat less aggressive immunoablation procedure, which was non-myeloablative. In other words, it did not completely deplete other white blood cells. And the follow-up was for a median of 2 years in this recent report, with some patients having been followed up to 5 years. And so this study also showed very potent benefit with not only less worsening of disease activity and less worsening of disability, but in fact improvement in a substantial proportion of patients. This study has the advantages of a somewhat larger sample size. With the approach used for immunoablation, there was better tolerability and better safety, and there were still very good results in terms of benefit, not only less worsening and less activity, but in fact improvement. But the main drawback of this study, again, is that it was an open-label case series, so some of the results potentially could have been due to expectation, in other words, placebo effects, or the recovery from relapses just prior to the transplantation. But this study also provided some very important information about this approach. So from these studies and other studies, we feel we can say that at this point the indications are that this approach is highly effective in active relapsing-remitting patients. And the patients that are most likely to benefit are those that are young with a relatively short disease duration and who still have preserved neurologic function, but are continuing to have inflammatory disease activity manifested as relapses or MRI lesion activity, despite treatment with standard agents. What is the main drawback of this approach? Well, the main drawback is cost and toxicity. Now, most of the toxicity is up front. It is related to adverse events around the time of the mobilization or conditioning or the transplant procedure itself, consequences of the drugs used to accomplish that, or secondary complications of myelosuppression and immunoablation, the most common ones being infection or hemorrhage. Most of the toxicity is up front, but there has been some late toxicity, primarily the emergence, rarely, of secondary autoimmune disorders. So for me, the emerging data suggests that this is a highly effective therapy if used in the appropriate patient. And the main question remaining is, where does this approach compare to other potent approaches that are already available, such as natalizumab or alemtuzumab, or other therapies that are soon to be available, such as the CD20 B-cell depleting monoclonal antibodies. So one of the conclusions of the workshop that I described earlier is that to place this therapy in the overall treatment algorithm probably is going to require a formal study to look at its utility compared to these other potent therapies. All right, so let's now talk about, let's turn our attention to stem cell approaches that primary goal is to repair the damaged nervous system. And there have been several cell-based approaches that have been examined for this. One of which is embryonic stem cells. So these are cells isolated from the early embryonic development. They have the hypothetical advantages that they have indefinite self-renewal capability, and they're pluripotent. They have the ability, in principle, to generate any tissue in the body. The main disadvantages are there obviously are both practical and ethical issues with using embryonic stem cells. And secondly, that the protocols to induce these cells to develop into the cell types and the tissue that's desired have not yet been completely worked out. And one thing that we would want to avoid is the administration of embryonic stem cells that develop into the wrong cell type, or in fact even become a teratoma within a tissue. A second cell type that's been examined has been either progenitor cells or precursor cells, specifically oligodendrocyte precursor cells. So these are cells that could be derived from the developing embryo, or from fetal tissue, or from neonatal tissue, for example, abortuses, or from adult tissue in principle. The advantage is that these cells have already partially committed to the desired cell type, so presumably it would not be as complicated to stimulate them to complete maturation. The disadvantages are that these cells have many of the same practical and ethical issues as embryonic stem cells. Because they're partially committed, they have somewhat less proliferation capability. The indications at present are that they don't have very robust ability to enter the nervous system from the outside, so they have to be directly injected into the nervous system. And then finally, it's unlikely with our current methodology that we could isolate these cells from the patient themselves. So in other words, they're going to come from an HLA mismatched donor, so the recipients are probably going to require immunosuppression because they're in fact receiving an allogeneic transplant. Now, one approach that's gotten a lot of attention as a way to address some of the shortcomings with embryonic stem cells and progenitor cells has been the so-called induced pluripotent stem cells. So as illustrated on this slide, these are cells that are isolated from adult differentiated tissues, for example, a skin biopsy, and then they're genetically reprogrammed, turning them back into stem cell-like cells, and then further treated to differentiate them along the line to the cell type of interest. The main disadvantage is that they are highly manipulated, and as a result, the clinical protocols do not yet fully exist to know how to administer them safely. So this figure illustrates that general approach. So these would be cells that you could isolate from the patients themselves, for example, from a skin biopsy. And then in the laboratory, those mature skin fibroblasts could be reprogrammed into stem cell-like cells. And then by further manipulation, differentiated into, for example, cells that look and function like oligodendrocyte precursors. So this would have the advantage that these would be cells from the patient themselves that presumably would not be rejected and would not require immunosuppression. Now, the main issue with these cells is what I alluded to before, which is that these cells are highly manipulated and in fact have been shown to have frequent genetic modifications, including in some cases mutations in genes that have been implicated in neoplasia or in cells becoming abnormal. And so at the very least, cells utilized for this purpose are going to require very extensive genetic screening prior to use. So the final cell type that I'm going to discuss are so-called mesenchymal stem cells, because these are repair-promoting cells that are probably the closest to prime time. So these are cells that are isolated from the adult, as shown here, including potentially from the patients themselves. They can be isolated from a variety of tissues. Most of the work to date has been done from these cells isolated from bone marrow or from adipose tissue, but they're in fact present in many other tissues. The advantages are that they are relatively easy to isolate, and they can come from the adult. Methods exist to culturing them to high cell numbers and pure cell populations. These cells have a variety of biologic effects that one would think would be of benefit in multiple sclerosis, and they can be administered via a variety of routes, which we'll talk about in a second. I would say the main disadvantage at the moment is that with current cell production techniques, they have a finite proliferative capacity. So one cannot grow these cells indefinitely. Eventually, they stop growing in culture. So this slide illustrates the multiple properties of mesenchymal stem cells that make many of us think that they potentially may be of use in treating a variety of diseases. So starting from the left, they have a wide range of immunomodulatory effects on a number of aspects of immune function, many of which we think are relevant to multiple sclerosis. Skipping over to the third column, they have the ability to differentiate into mostly mesodermal derivatives, so they can develop into bone, cartilage, and connective tissue. So they can be utilized to repair those tissues, but they also may have the ability to differentiate into other lineages. And under some conditions, they can be made to express features that suggest nerve cells or oligodendrocytes. We think, however, that this transdifferentiation, as that's known, probably is not going to be important for their potential beneficial effects in multiple sclerosis. Rather, we think, as illustrated in the second column from the left, these cells are able to produce a wide range of trophic factors, including trophic factors for neurons and oligodendrocytes and their progenitor cells. So we think that their main ability their ability to potentially promote repair in the central nervous system is probably by serving as a source of neurotrophic factors and creating an environment that's more conducive to the natural repair mechanisms. A couple of other properties that may be of use, they also have the ability to stimulate the formation of new blood vessels. This probably is not that relevant for multiple sclerosis, but may be relevant for vascular diseases, including stroke. And then finally, a very useful property of these cells is that they have very marked migratory capacity within tissue and to migrate into tissue from the cerebrospinal fluid or blood, so that they can be administered either via spinal tap or intravenously, and then they find their way into the inflamed or damaged central nervous system. And then once they get within the central nervous system, they're able to migrate throughout the tissue, finding areas of damage for which they may be able to promote repair. So this represents a very convenient potential aspect of their biology. So as a result of those properties, mesenchymal stem cells have been looked at in a wide range of both inflammatory and tissue injury conditions, as listed on this slide. Probably most of the work has been done in malignancy and as a treatment for graft versus host disease and in heart disease. But now a number of studies have been published in a wide range of other conditions, including several neurologic conditions, including multiple sclerosis. So this table lists the published studies of mesenchymal stem cells in multiple sclerosis. I'll make several general points about them. So first of all of these studies reported some indications of benefit and showed good feasibility and safety. But there are a number of caveats. So first of all, the total number of studies is relatively small, and each of the studies enrolled a relatively small number of patients. So the overall experience in MS so far still is relatively modest. Secondly, these studies differed to a great extent in how they were conducted, including which patients were treated, from where the cells were isolated, how the cells were grown in culture, and finally the route by which they were administered. So when this experience was discussed at the cell-based therapy workshop I referred to before, the conclusion was that this was a very useful start. The results were very reassuring, but more formal studies were needed before we could determine the utility of this approach in multiple sclerosis. So here are what I consider the main questions concerning mesenchymal stem cells in MS. So first of all is, for what purpose should they be utilized? Should they be utilized for their anti-inflammatory properties, or should they be utilized as a way of promoting repair in multiple sclerosis, or some combination of those? That has important implications because it determines how one designs the studies that need to be conducted. The other point that became very clear as we discussed these cells at the workshop was that there still are there still is a large number of very fundamental methodologic questions concerning cell production and administration. And these include things such as what's the best source of these cells, what cell production protocols should be utilized, should we use cells that have been cryopreserved and thawed just prior to administration, or should cells be taken straight from culture? What's the best route of administration? How many cells do we need to inject? How long does their benefit last? And is repeated dosing going to be necessary? And then finally, getting at this question of whether the stem cells from a patient with MS themselves are deficient. Should the cells come from the patient themselves, because that avoids a number of other methodologic issues, or should they better come from someone who does not have MS? The reason why these points are all important is that if one goes online, one can find a large number of clinics offering mesenchymal stem cell transplantation for a wide range of conditions, including multiple sclerosis. And I would propose that there still is a large number of questions that we haven't answered, and it's premature to be offering these cells in this cellular approach on a fee-for-service basis. So in conclusion, just to summarize what I've told you, there are, in fact, several types of cell-based strategies that are under investigation, each of which has a different purpose, its own risks, its own potential benefits, and the goals that we wish to accomplish. Many of these strategies show promise, but there still are many unanswered questions that need to be addressed before this can be utilized as a standard therapy. And so at this point, I would say that stem cell transplantation is not yet appropriate as a general treatment for multiple sclerosis, but it shows a great deal of promise. There's a great deal of activity in the field, and hopefully progress is now going to accelerate in this area. So thank you for your attention, and I will conclude here.
Thanks, Dr. Cohen, for your balanced review of the biology of stem cells and their potential application to MS therapeutics. You remind us that immunoablation and autologous hematopoietic stem cell transplantation is a viable treatment which presently we use in very aggressive forms of MS in otherwise healthy young people who break through on standard disease-modifying therapy. You review your work and that of others in using mesenchymal stem cells for treatment, noting the very exploratory nature of this work at present. You make the excellent clinical point that at this time, most stem cell therapies remain experimental for MS, and they are not part of standard clinical care. We hope to see more progress in this exciting area of neuroimmunology and cell biology.